Welcome, everyone. I'm Donald Weeks, founder and CEO of ClearPath AI and host to the Clinic Efficiency Podcast. I'm really excited for today's conversation. Today, we have Jane Wood. She's the president for the New York State Clinical Laboratory Association. Welcome, Jane.
Thank you very much, Donald. Happy to be here.
Thank you. Well, please tell us a little bit about your background and a little bit about your work there at New York State Clinical Laboratory Association.
Certainly. I have spent almost 40 years representing laboratories as a lawyer, although I did retire at the end of last year from the legal practice. So most of that time was spent in private practice representing a wide variety of laboratories, clinical laboratories, anatomic pathology laboratories, genetic laboratories, large academic medical centers, small mom and pop labs, independent laboratories. I also spent almost 8 years as general counsel for a large independent clinical laboratory as well. I have been a member of the New York State Clinical Laboratory Association's board for about 10 years now. And this past year, I'm now a year and a couple months into serving as the president of the New York State Clinical Laboratory Association. NISCLA's purpose is to promote the interests of laboratories that are in the state of New York, as well as out-of-state laboratories that have a New York State license. Many people may not be aware that New York is very strict when it comes to laboratory licensure. So even if your laboratory is out of state, if you're going to test any specimens from someone who is in New York, you still need to have a New York State license. So we're very active in terms of education, lobbying. We have a lobbyist with whom we engage and have for many, many years to track state legislation, to make sure that the legislators in New York, as well as the appropriate departments, the Department of Health, the Department of Education, which actually licenses lab personnel in New York, that they're all attuned to what the needs of our members are.
All right. Well, that sounds great. I mean, you're nearly 40 years as a lawyer representing laboratories and diagnostic healthcare providers. Well, that gives you an unparalleled view into the operational realities and regulatory complexities of clinical laboratories. It's a pleasure to have you today. Now, your career has been dedicated to representing laboratories and diagnostic healthcare providers. What initially drew you to this specialized area of healthcare law, and how has your focus evolved, especially concerning the operational efficiency of clinical labs?
Well, I have to confess that I fell into representing healthcare providers. I actually began my career thinking I'd be a real estate lawyer, and I was a first-year associate, and some pivotal pieces of legislation came out. The Stark Law, which initially only regulated relationships between physicians and laboratories and then expanded to regulate relationships between physicians and other types of diagnostic providers, as well as the Clinical Laboratory Improvement Amendments of 1988, which is the foundational piece of federal legislation that regulates laboratories in the United States. And as a young associate in my firm, I was given the job of reading these laws, coming up to date on them, and found myself speaking about them. For some of our clients, we had one client in particular who was president of the American Pathology Foundation at that time and needed someone to speak about it. So before I knew it, I was a healthcare lawyer and I was representing laboratories. Again, not with any particular design, but a fascinating area. I do represent a wide variety of healthcare providers, and I'm not sure there's any other type of healthcare provider that is as regulated as laboratories are, because not only is there a federal scheme of regulation, but it's also a state regulatory scheme. And because so many laboratories operate across multiple states, they are then subject to those multiple jurisdictions. In addition, to complicate things, the reimbursement rules, the Medicare rules, the Medicaid rules, even the state legislation can differ whether one's doing clinical laboratory testing, anatomic pathology testing, cytology testing, or molecular testing. So laboratories have to juggle all of these rules in order to operate, particularly if they're doing multiple types of testing on an interstate basis.
Wow, that's very interesting. I know the New York State Clinical Laboratory Association focuses heavily on lobbying, legislative efforts, and dealing with payers. How do these external factors directly impact the day-to-day efficiency and financial viability of clinical laboratories, particularly with the smaller independent labs?
A bit, particularly in New York, which is one of the more heavily regulated states for laboratories. California would be another one, for example. There Are many regulations to comply with, which means laboratories need to have the resources to understand these regulations and to make sure that they are in compliance. For a larger laboratory that may have an in-house legal group or have the resources to contract with outside counsel or other advisors, I'm not saying it's easy, but it can be, and it's less difficult to tackle. For a smaller independent laboratory, or particularly a laboratory where the margins are very, very tight, it can be difficult to keep up to date with all the regulations. The downside is someone may try to save money, not spend the money to have the outside consultants to assist, but then later they may find themselves out of compliance. Worst case scenario, you get shut down by the state. That's the death knell. But other consequences can be you may not be paid for your testing, you may have fines or penalties to pay. It can be very much a penny wise, pound foolish move to not spend the money to stay up to date. There's also a fair amount of just smaller laboratories not understanding the scope and breadth of the regulations with which they need to comply. Because, as I mentioned, laboratories are regulated on so many levels, someone might say, I just moved to New York State and I was previously working in Massachusetts. And I think I know the federal level without realizing the complexity of the state regulations, or vice versa. Again, quite a bit of challenge. And one of the things we're hoping to do at NISCLA is provide resources to guide people to say, here is what you need to follow. I mean, even this morning, I had a call from one of our members just asking a fairly simple question, but the question was, where do I find the answer to what this laboratory assistant can do?
Right. Yeah, very good. Well, you highlighted budget constraints and a huge shortage of skilled laboratorians as significant operational hurdles. How are laboratories trying to manage these challenges, and what role can technology like AI play a role in maximizing the highest and best use of their human capital?
For laboratories and laboratory medicine now, the number one critical issue is personnel shortages. And that's true of much of healthcare as well. It's not unique to laboratory, but it is very acute. There are some estimates now that within the clinical laboratory space, the vacancies for laboratory personnel as well as for pathologists to be laboratory directors range between 20 and 30% vacancies. That's a huge, huge issue.
Right.
What that means is it is critical for laboratories to save the living bodies, the brains of the people working for them for the highest and best use. And really spending the time to say, okay, so if we want to save our people for their highest and best use, what are the more routine tasks that we can relegate to technology, perhaps to AI, but keeping in mind the regulatory as well as safety and practice of medicine issues. Obviously, we cannot have AI practicing medicine. We have to be mindful of that. But we can have AI tools, which are an assist for laboratories to improve efficiency, to be a double check on things, to take some of the burden off the mindless tasks, and the same with technology. We do run into a little bit of a catch-22 here, though, because as everyone knows, to implement some of these technology, efficiency goals takes money. And if you're already in a very tight resource area, it can be difficult to find the funds to invest to actually save money in the future. And that's another challenge many laboratories have now. And that's the reason many laboratories are looking for some additional sources of funding to assist them in implementing the technology that they really need to keep going in the future.
Right. Yeah, that's good. Well, a follow-up question on that is, you know, we've discussed the increasing role of AI in healthcare and particularly in anatomic pathology for initial screenings. What are the key legal and regulatory considerations that laboratories must navigate when adopting AI tools, especially in avoiding triggering FDA reviews or compliance issues?
Certainly. And there's several of them. And I think they're workable. The important thing to remember with AI, particularly if we're talking about the practice of medicine in anatomic pathology, I'll take that first before we get to clinical lab. And it's the same issues that arise, say, in law, practicing law. I can't have AI write my legal brief for me. I may have AI assist me, but I'm responsible for what's in that legal brief. I must review it. I have to ensure that I have given the legal thought behind it. Becomes even more complex in a medical area. I don't kill someone practicing law, but obviously someone practicing medicine can have some very adverse patient consequences. So certainly, first and foremost, from a patient care standpoint, it is critical that trained laboratorians, a pathologist who's involved in performing anatomic pathology, professional component services, is using that training to make the final diagnostic decisions. But having said that, one can still use AI as an assist, but it's an
Yeah.
assist. It is
Right.
also important because obviously pathologists and others are billing third party payers for services. If you're going to bill and submit a claim for a professional anatomic pathology diagnosis, that is the practice of medicine. If AI has performed the review and that pathologist set of eyes has not reviewed it and given an independent pathological judgment from an MD or DO on that, then that would be a false claim submitted because no medicine was actually practiced by a licensed physician for diagnosis for that was submitted. So on the anatomic pathology side, I think the important thing to remember, and holds true for physicians and other specialties as well, who are using ChatGPT or Claude to assist with diagnostic decisions. These are tools, they're assists, but they're not making the decision. Clinical laboratory is a little bit different because we can also use AI with some of the algorithms or other things that are going into technical clinical laboratory testing. This is an area where the FDA, as well as some states, state of New York would also be there. They are struggling a bit with how to ensure that the AI has been properly validated, that this is appropriate for quality testing, replicable quality testing. And that is an area where I strongly would advise any laboratories looking at implementing what may otherwise be non FDA cleared or approved technology into their clinical laboratory operations to consult with counsel to ensure that are they doing it via an LDT, laboratory developed test route, that might be viewed as permissible? Or are they crossing over into an area where the FDA is much more likely to be concerned about what's going on?
Right. Absolutely. Yeah, I've seen that with kidney, diagnoses as well, where they're using that as, and that is one of those areas where they've got to get that, advice from the council. You've mentioned the importance of good advisors and staying up to date on regulations to avoid costly mistakes. What's one piece of actionable advice you would offer to clinic administrators or lab directors who are striving to optimize their operations while ensuring robust legal and regulatory compliance?
I'll actually give two. One of them will be free, and the other one may have a cost to it. I'll take the one with the cost to it. Is there are quite a large number of some very, very good national laboratory associations. Now, again, someone has to pay to be a member of the association, but those national laboratory associations are very, very good about keeping their members up to date on developments, particularly on a federal level, as well as doing lobbying, engaging, being resources for information. So, on a federal level, think very hard about those organizations. If you are in a state, this will be my plug for NISCLA, but I would also say the same thing with other states that are very heavily regulated. You may want to consider a membership in a state organization. Usually those are much, much less expensive to have that membership. And then you have resources, you have access to information. The other one to consider quite a bit is many law firms, including my former law firm, have blogs, they have postings, sites, and law firms are happy to have anyone sign up for free to receive their newsletters. And so if you look at law firms that represent a lot of laboratories, just sign up for their newsletter. And you'll probably once or twice a week be getting some very actionable information. Doesn't cost you a penny.
Right. Yeah, that's very good. Well, considering the razor thin margins in the laboratory industry and the challenges with payer reimbursements, what are some common pitfalls you've observed when medical practices try to add in house lab testing? And what advice would you give them to avoid these issues?
I think it's very important to recognize that payers are skeptical of a lot of laboratory testing, particularly when it's been insourced into a clinic or a physician office as an ancillary revenue stream.
Right.
During the pandemic, we had this brief little period where laboratories were heroes. And then that quickly went away. And unfortunately, associated with the pandemic and the post pandemic era, there has been admittedly a lot of abuse in testing. there were a lot of laboratories that popped up to do COVID testing. And they have now pivoted with now that there's no demand for the COVID testing to other types of testing. In particular, those laboratories are using some of the machines for PCR testing, for genetic testing. So PCR testing, this would be urine PCR testing, for example, would be fairly common, as well as genetic testing are very, very highly scrutinized by payers. So for anyone who's looking at insourcing testing, particularly testing in those areas, be aware that payers have very strict payment guidelines. They may only reimburse so many units. For a lot of PCR testing, payers will only pay for, I'll take the example of urine PCR testing, if there is medical necessity documentation showing that either a urine culture has failed, has been inconclusive, or the patient's medical condition is so delicate, there's such patient jeopardy there that it would not be wise from a patient care standpoint to wait the extra time to have a culture done. So what happens is for many providers is they may implement the testing because they've been said, hey, this will be great for your patient. You'll get quicker turnaround with the PCR testing. Won't have to wait for the culture, more definitive diagnosis. It'll be great. And you make some pretty good money from it. After a year of testing, then Medicare or Blue Cross or another payer comes back and audits and they ask, where are the medical records to document that the patient met those criteria? That the patient actually had such a critical medical condition that you couldn't wait for the culture. And unfortunately, if that doesn't exist, all those dollars are recouped. At that point, no one's made any money from this. And
That's right.
we're in the hole. So my advice to anyone looking at insourcing testing of any type, but particularly in the genetic PCR testing, because those are very critical areas. Toxicology would be a third one where payers are particularly suspicious of overutilization, is take the time to find out for your local Medicare MAC, as well as the major payers in your area among your practice, who your major payers are, what their policies are for reimbursement. Whether there's a limit on units, what kind of medical necessity documentation they require, whether they even reimburse for it at all, or whether they require prior authorization. Another big hurdle. Obviously, not going to be unique to most healthcare providers, the prior authorization issues. But unless they're aware of these things, they may get started down a path and then find themselves really in the hole later.
Right. Absolutely. Well, I think it's very sound advice. That's very good. Well, Jane, thank you so much for sharing your insights. I think this has been incredibly valuable, and I really appreciate your time and openness this morning.
Oh, well, thank you, Donald. Happy to give
Yeah.
some thoughts.
Thank you. Yeah, it was very good. Well, before we wrap up, is there anything like on your end that we maybe should have covered as well that is coming up, in the what you're seeing right now, especially in New York?
Well, it's the tighter margins. I would say, particularly in New York. But again, we touched upon that, but it's becoming
Right.
even more acute now. What will be interesting to see is funding on a federal level for Medicare, because we know so many healthcare providers are so highly dependent upon Medicare, and most laboratories are highly dependent upon Medicare as well, to
Right.
the extent that we may see additional cuts in Medicare funding, particularly to fund the war
Right.
in Iran. Again, we have a couple weeks here that we got to see what's going to happen.
That's
But
right.
there's certainly a lot of discussion regarding what's going to happen with the Reconciliation Act and will we see cuts to healthcare spending. That's going to make the margins even tighter and more difficult for healthcare providers.
Well, thank you so much, Jane. I do appreciate it.